First of all, a huge thank you to the organizers of this UVSCME to, having me, in giving me a chance to come back to beautiful Pondicherry. I'll never miss an opportunity given a chance. And also huge thanks to Balamurugan, Dr. Balamurugan, for giving this very unusual but very relevant topic, namely challenges in history taking. So I'm not going to go into the theoretical aspect of history taking here. I'm just going to share with you the practical tips and the common difficulties and challenges you will face as you, take history from the patient and, share some of my experience. So you know that along with a thorough clinical examination and appropriate investigations, history is one of the cornerstones of managing uveitis cases. So this great physician, William Osler, also considered one of the greatest teachers in medicine, has said, listen to your patient, he is telling you the diagnosis. But to listen to your patient, you also need to ask the appropriate questions. I don't know, I think at least some of us would have had this experience, especially when you're a junior, you see a case and you work up, you take history, you examine, and then you go and present it to your senior, and suddenly the patient will come out with, a lot of information which they never told you. Have you had that experience? And then you're left, feeling very red-faced and telling, but I asked, but the patient never told me. So this is a case of cytomegalovirus retinitis. And you know that it has a, very close association with HIV. But, how many patients are going to come out and tell you, that they have this particular disease? So we will look at some of the reason why patients, may not give you proper answers when you ask them. And the most common is that just like any other human being, just like you and me, they hesitate to share sensitive information with a stranger. And that's because they're scared that, they might be treated differently, you might judge them, or they might be in a situation, where they don't want the attendant to know, very personal information. So you need to be sensitive to this, empathize with the patient and make sure that they're in an environment where they can safely, and openly talk to you. Secondly, sometimes, patients may not think that, their health issues are related to the current eye problem. For example, they may not think that a rash, a vesicular rash which they had on their forehead, many years ago is related to a pain and redness in the eye. So you might have to ask very leading questions, in that direction. Or, they might have completely forgotten about it. For example, primary complex, which they had in childhood. So you'll have to ask them to go back, get back to the family, talk to elders in the family, and then get back to you. So it's not, often it's not what you ask, but how you ask that matters. The second issue with history taking, and which I commonly see with the students, is that, they will ask for history and just write, the patient has oral ulcers, the patient has skin rashes, the patient has back pain, without going into details. So the answer lies in details, actually. So to go and give you an example, after ulcer, oral ulcers, I'm pretty sure all of us would have had oral ulcers, at some point in our life. But it's also a very important diagnostic criteria for Behçet's disease. And in this situation, it's painful, it's recurrent, and by definition, it has to be 3 or more episodes per year, okay? And it also tends to be multiple, herpetiform, like in this case, large lesions, and can affect unusual sites like the soft palate, the hard palate, and the tonsils, okay? Or take the example of low back pain. I think every other person is, suffers from low back pain, but you know that it's a very important clue to seronegative spondyloarthropathy related uveitis. And in this case, the age should be less than 45, duration of more than 3 months. And very classically, the inflammatory back pain will worsen with rest and improves with exercise. So classically, if you ask them, they say the pain is worse when they get up in the morning. They have trouble bending down. There's a lot of stiffness, and it gets better as they move around. And that's what differentiates it from other causes of back pain like disc prolapse or a muscle pain. The third point in history taking is, you have to establish timelines. So by that, what I mean is, how did this disease begin? How did it progress? Did you have any treatment? And you have to have all details of treatment, like what kind of medications were given, what dose, and for how long, and whether they were compliant with the treatment. Okay, so in this day and age, you'll find that, okay, a certain percentage of patients might come to you first time, but in many situations, they would have already seen one or two other doctors, they would have had some form of treatment. And, you really need to establish the timeline. So if a patient is coming to you with an active problem, there are only 4 reasons for it. Either the diagnosis is not correct, or the treatment is not adequate or appropriate, or they have developed a complication, or they are non-compliant. So you can differentiate the 4 only by going into details of the past history. So this is a patient who was referred to UVA department as exudative RD, treated as leakage from outside with oral steroids. And you can see that, you have these yellow looking lesions here. There are a few scars, and there's exudative RD in the left eye. When we asked, he said, he never had pain or redness to begin with. He just had blurring of vision. He was started on 40 mg oral steroids, which didn't do him any good. He actually worsened. So look what the FFA shows. This is not leakage. This is central serous chorioretinopathy. Okay. So moving on to the next point, it's been said, it is much more important to know what sort of a patient has a disease rather than what sort of a disease a patient has. By that, what I mean is, you need to know your patient inside out, okay? What do they do for a living? What do they eat? Who do they interact with? What about their family members? Are there any pets at home? All these are going to be important clues in pinpointing the diagnosis of uveitis. I'm going to again talk about another case, which has been a huge teaching point for me personally. So this is a 13-year-old girl who was initially treated by one of my colleagues, who is an ex-alumni of Aravind Coimbatore. And he called up to say that he has this patient who has developed right eye severe keratouveitis and vitritis after chickenpox. So after discussion, we decided that she needs to be started on oral antiviral after pediatrician consultation, along with the topical antiviral Predfort and cycloplegics. But few days later, this patient turns up in UVA clinic, Aravind Coimbatore, with a worsening. In the left eye, she has now developed retinal vasculitis, diffuse retinal vasculitis, and the right eye is worse. The severe corneal edema, there's no view of the back of the eye. Now, the child is accompanied by an elderly gentleman who is her maternal grandfather. So after examining, I decided that we need to start steroids, along with the antivirals, under cover of antivirals. So I asked for Manto, CBC, chest X-ray, TPHA, and then asked them to come back after 3 days. 3 days later, the child comes back, still accompanied by the maternal grandfather. And all the tests are negative, all tests are normal. She's got a slightly elevated ESR. So this time around, I asked him, what about her parents? What about her father and mother? And he said, her mother, who's his daughter, she's at work, so she couldn't make it. So what about the father? He said, he passed away and he was a good-for-nothing fellow. Okay. And suddenly, alarm bells started ringing because I looked at the child and I thought, she's a little bit underdeveloped for her age. I sent her for HIV testing and she was positive. Okay. So since then, if I see pediatric patients, I don't stop with, who the informant is. I always ask after the parents, whether they are in good health, whether they are alive. It makes a lot of difference. I'll share one more patient. This is a 44-year-old lady who came for second opinion from Bangalore. She had decreased vision in the right eye for a year and a half. She was treated for posterior uveitis with oral steroids and 5 injections of Avastin for secondary CNVMs. Okay. And no cause has been found. All our investigations have been negative. And this is the montage fundus photo of the right eye. Left eye was absolutely normal. You can see the CNVM, which looks inactive. And what is striking is this very linear, continuous, track of scars in the equatorial region. So I've never seen anything like that before, but I kind of remembered from the textbook, this can happen in ocular histoplasmosis, and there was no vitritis. So actually shared the pictures and the history with a collaborator in US. And this is a direct quote from his mail. I agree that this could be compatible with presumed ocular histoplasmosis syndrome. And these lesions are known as Schlegel lines. It can be seen in POHS as well as multifocal choroiditis, but multifocal choroiditis with pan-uveitis is usually bilateral, not unilateral. So this patient used to live in West Virginia, US in the past. And that is the map of US showing the distribution of endemic mycosis, and there's West Virginia, endemic for histoplasmosis. So knowledge is power. And what your mind doesn't know, your eyes will not see, nor will your ears will not hear, okay? So Osler has also said that he who studies medicine without books sails an uncharted sea, but he who studies medicine without patience does not go to sea at all. So like Dr. Bala just said, when you do your post-graduation and your fellowship, you think, you're qualified, but you're only starting your education. You're only laying down the foundation. And that fellowship gives you only the tools, to analyze the patient. So the learning is a continuous thing, which you continue to learn throughout your life. So one more case, we have what is called grand rounds, every week, where the PG students, present a rather unusual case, and it's moderated by the consultant. So a few years ago, my retina colleague called to say that, one of the students want to present in grand rounds, and he knows he has seen a case of posterior scleritis caused by bisphosphonate, okay, which is used for treating osteoporosis. So he asked me, do you know anything about it? Would you like to join us for the moderating? So I honestly said, I've never seen a case before, I'm clueless, but I will look at the presentation. I'll also look at the articles, and I'll get back to you. So I did that. And lo and behold, a few weeks later, I get this elderly lady presenting with pain, redness, and reduced vision in both eyes, and a hypopyon uveitis in both eyes and mild vitritis. She's never had uveitis ever. She's in her 60s, okay? And she said the only thing that has happened to her, she's got an injection 2 weeks ago for osteoporosis. And this is zolintronic acid-induced hypopyon uveitis. So because, I had that information, I could make the correlation, avoid an unnecessary AC tap, vitreous tap. And she responded very well to topical steroids and PSD. So this is going to keep happening because we have already moved into the era of biologicals and immune therapy. And this entire group of medication called checklist inhibitors used for treating melanomas and metastatic carcinomas, which can produce a range of uveitis, including BKH-like syndrome. So you have to update yourself. You have to be aware of this to avoid unnecessary investigations, delay in treatment. You also need to get back to the treating physician to avoid the medication in future. So you'll have to keep updating yourself. And this is the last case. Suppose you have taken the history, you have done the investigation, thoroughly examined the patient, and you're still clueless, I would say go back to the history. So this is so we were thinking, it's a very unusual picture. We were thinking whether it's atypical CSCR, VKH, syphilis, all that's running through our minds. We get the OCT, and you can see the subretinal fluid. You can also see this very hyperreflective thickened retinal pigment epithelium, and this sheet of hyperreflective material lying over it. And if you look at the autofluorescence, you can see the confluent hyperautofluorescence in the macula with patches of hypoautofluorescence in both eyes. And these lesions are actually window defects. You can see that, they're there in the earliest frame, and they increase in intensity, but not in size. But there's also pooling due to the subretinal fluid. So all is baseline, TB, everything was negative. This picture is not suggestive of VKH. And 2 weeks after his initial presentation, while we were all wondering what's happening, he comes back and there's a spontaneous reduction of SRF in both eyes. And we all heave a, sigh of relief. Okay, maybe we don't have to do anything. We'll just sit on it. And again, he comes back after 2 weeks, the subretinal fluid has increased. Okay. Same in the left eye. That's the first picture. This is 2 weeks later, there's reduction. And then another 2 weeks, it's spontaneously increased again. So we go back and take the history, and he's a very frail, old looking man. And he said, he's had a history of loss of weight, altered bowel habits, and we referred him to oncologist. Turns out he has CA colon with widespread metastasis, okay? So what you're looking in the eye is a very rare condition called acute exudative paraneoplastic polymorphous vitelliform maculopathy, okay? Which can be associated with uveal melanoma, adenocarcinoma, lung, and breast carcinoma. So when in doubt, ask questions. If you don't get answers, ask questions again and again until you find answers. Thank you very much, and thank you for patient listening.